My name is Matthew Menendez with White Plume. I'm going to be leading the webinar this afternoon. This webinar is, again, designed for orthopedic practices, and we're going to go ahead and jump right in. Let me talk quickly about our agenda for the afternoon, what I hope to accomplish in the next 45 to 50 minutes. I'm going to start with some background information on ICD-10. Most of you should be familiar with what ICD-10 is thus far, so we're going to take a bit of a different approach here. We're going to look at some of the things that makes ICD-10 so difficult here in the United States. Right? There are some things that our government has done that makes that more challenging than a lot of the other countries who've already moved forward with ICD-10. You know, you probably have heard that before. A lot of the other World Health Organization countries have already moved to ICD-10, and that's true. But there are some things that make this uniquely challenging here in the United States. So we're going to talk about that. A lot of practices are behind in their preparation, right? They're not where they need to be yet, and they're going to be using the next months to try to catch up and make sure they're well prepared for the transition. So I'm going to share some mistakes we've seen other orthopedic practices make. So hopefully you can learn from those mistakes and not duplicate them in your practice. And then the last thing I want to do by way of introduction is dispel some of the myths out there about ICD-10. There's a lot of misinformation, right? There's a lot of bad information out there about ICD-10. And that doesn't serve a very good purpose. A lot of practices will get scared by that. They're paralyzed by how difficult it seems, and they don't take the steps they need to be prepared. So we want to take a good look at what ICD-10 is and what it isn't so that you can be prepared. And then we're going to get down into the details to understand what the impact is to your practice. How do you understand what that is and communicate that to your staff and to your providers? We'll show you some tools and resources that are available to help you do that. And a few themes that you'll hear throughout our time today. The first thing we're going to talk about, and the thing that is most critical for an orthopedic practice to successfully transition to ICD-10, is protecting doctor productivity. If our doctors aren't taking care of patients, nobody else in the practice is. If our doctors aren't generating revenue for the practice, nobody else is. And at the end of the day, if they're not doing those two things and your doctors aren't happy, nobody else in the practice will be either. We have to protect their time. But the second part of this is equally important. You have to make sure that you get paid for those encounters. You have to keep your cash flow going, and that requires the correct ICD-10 codes. So how do we do that without turning your doctor into a coder? How do we do that without adding staff? We're going to talk about some strategies to be successful in that area. The other theme that you'll hear throughout our time today is the difference between ICD-10 compliance and ICD-10 productivity. A lot of people assume that ICD-10 is really a compliance-only event. They treat it like a pass-fail course in college. You want to do enough to pass, but you don't want to do any more. And that's not a good way to think about it. There will be some practices who are very well prepared, who thrive during this transition, and there will be other practices who don't do so well. I want to make sure we talk about that so you can make a conscious decision as to what strategy is most appropriate for your practice, rather than just assuming by default that the target is ICD-10 compliance. I'll certainly make sure that we leave time for questions and answers at the end. For those of you that are just joining, everybody is in listen-only mode. So we're going to, if you want to ask questions, if you have comments or feedback, use the questions panel for that. I'll try to answer as many of those questions as I can. Feel free to ask those during the presentation. I'll get to as many of them as I can at the end. If there are any that are just specific to your practice, we can follow up with you offline about those. So let's dive in. What makes ICD-10 difficult here in the United States? What makes it hard for an orthopedic practice? Well, the first thing is ICD-10 is a one-day conversion. I'm sure everybody has seen this by now. October 1st is D-Day for ICD-10. It's a one-day conversion. That means there's no transition period on the where you can slip the date or you can do this 2 weeks late. Now, you might say a lot of other countries had a one-day conversion too. How's that different in the United States? Where that is different is this is not our first ICD-10 conversion date, right? As most of you know, ICD-10 has been delayed 3 times already. Twice by CMS, most recently last spring by Congress. And that's created a lot of uncertainty around the conversion date. You have a lot of people, rather than taking the necessary steps to be prepared, that are hoping that it's going to get delayed again. It's a lot like the story of the boy who cried wolf, right? Everybody probably remembers that. At the end of that story, when the wolf actually comes, it's not the boy who pays the price. He's lost his credibility, but the person who pays the ultimate price are the practices that are unprepared. The physicians in those practices, the staff in those practices, ultimately the patients in those practices. It's not the government who's going to pay the price. Now this is difficult because you may have people in your organization who don't want to spend the time, don't want to spend the resources to be prepared because they're hoping that it's going to be delayed again. But that looks very unlikely that that's going to be delayed again. All right, what else makes ICD-10 uniquely difficult here in the United States? Well, the next part is that it's a very big change for physicians. Now, you could say, well, wait a minute, wasn't it a big change for physicians in Canada and Australia, England, and France when they moved to ICD-10? Yes, it was, but the difference is those physicians are government employees, not small business owners. Our physicians here in the United States are paid based on their productivity. In our fee-for-service world, they cannot slow down. They cannot see fewer patients to deal with an unfunded mandate like ICD-10. And the part that makes this challenging for administrators or billing managers or ICD-10 project managers is also that our doctors aren't interested in ICD-10. They don't want to spend the time to learn about it. And I don't blame them. It's not a particularly interesting subject. But how do you protect their time? How do you protect their productivity? How do you prepare them to be successful if they won't spend the time up front? It's a very real challenge for a lot of orthopedic practices. We're going to talk about some strategies to mitigate some of those risks, but it's a very real problem. And the last piece, I think, is what's most difficult. You think about the environment that we're in, what's happened over the last 6, 7 years. There's been a lot of government intervention in healthcare. Think about all the programs we've had, e-prescribing and PQRI, or PQRS now, meaningful use, right? All of those programs changed the way we practice. All of those programs were optional, right? You could earn incentive dollars on your Medicare and or Medicaid reimbursement. They were all phased in. They all had a threat of a potential penalty down the road. And ICD-10 is completely different. With ICD-10, it's mandatory, not optional. It's overnight, not phased in. It's all of your payers. All HIPAA-covered entities are required by law to move to ICD-10, not just Medicare and Medicaid. There is no incentive. There is no carrot. It is all stick. It is all, quote, penalty. Now, I do want to make one comment here because there's a challenge here for orthopedic practices that a lot of other specialties don't see. And it's workers' comp. It's auto collision. Those insurance carriers are not considered HIPAA-covered entities, so they are not required by law to move to ICD-10. You need to check with those payers and ask them 2 questions if you've not done this already. Number 1, are you going to ICD-10? Number 2, if so, when are you going to ICD-10? Because that may or may not be on Thursday, October the 1st. So you need to ask them those two questions. But the other part that you need to think about here is it's not about just getting the code out on the claim. It's not just about getting an ICD-10 code there. You've got to jump through the hoops and hurdles that you do today to get the claim paid, because Medicare wants it one way and Blue Cross wants it another way. That's going to continue in ICD-10. It'll probably be a bit more complicated in ICD-10 than it is in ICD-9. So these are the big issues that make ICD-10 difficult in a physician practice today. Now, I do want to share with you some of the mistakes we've seen other practices make so that you might be able to avoid some of these as you're going through your work over the summer. The first one, and some of you may be victims of this, is, oh, we've got a coder or we've got a billing manager. That person is going to learn about ICD-10. That person is going to go to classes, is going to go to a boot camp session to learn about ICD-10. They'll have to deal with the change, but it won't impact the rest of us very much. Right? And when you think about that, yes, it is a huge change for coding and billing. Biggest change they've had in the past 30 years. But that's only part of a good, successful ICD-10 plan. A similar mistake that a lot of people make is the wrong assumption that ICD-10 is really just an IT upgrade. You see this on every ICD-10 checklist. Communicate with all your vendors. Make sure you understand which version you need to be on for ICD-10. And those are great recommendations. But we've all learned that it's not enough just to be on the right version, right? If you ask a vendor, are you going to be ready for ICD-10? The answer will always be yes. You need to go further than that. You need to understand, how is it going to work? What is it going to look like? Will it impact my workflow? Is that something that my doctors can do? Is that something that my staff can do? Is that something that will produce the right results for my revenue cycle? Show me how it works with my specific examples. Don't show me with primary care examples, because that's an entirely different world. Okay? You've got to view ICD-10 as a strategic initiative because what's at stake. And that means getting your management team involved, and that means getting your doctors involved. They don't have to be in on every single meeting, but they do need to understand the risks that are facing the practice and the strategies that you have in place to mitigate those risks. And what we recommend focusing on, right? Focus on, first and foremost, protecting your doctor's time. How do we keep them focused on taking care of our patients, generating revenue for the practice, and not dealing with all the administrative headaches of ICD-10? And secondly, how do I protect my revenue cycle? And when I say revenue cycle efficiency, what I mean here is, think about how many employees it takes, how many labor hours it takes to generate your cash flow today. Because if you have to add staff, or if it requires them to take more time to collect their cash flow, or if you collect less cash flow, or if it takes you longer to do that, those are all bad outcomes that we want to protect against. I'll share with you a study that was done by the advisory board. They do some very good ICD-10 consulting work. They looked at Canada's transition to ICD-10 and looked at the costs that happen post-implementation, post-ICD-10 date, the ongoing costs, right? This is the part of the iceberg that's below the water that a lot of people aren't paying attention to. And look what they put front and center: physician productivity. They saw a 10 to 20% decrease in physician productivity as a result of ICD-10. That is entirely unacceptable here in the United States for a busy orthopedic practice. You can do that if you're a government employee, but you can't do that as a private practice physician. Let's get underneath those numbers and understand what happened there. They had certified coders coding from the documentation, and those employees were having to go back and ask follow-up questions to the physician. I need you to be more specific here. Tell me more about the type of fracture. Can you tell me about the healing type? Which arm was it? And it was taking the providers 45 to 90 minutes per doctor per day to answer all of those questions. Even if you cut that number in half, where are your doctors going to find 22 to 45 minutes per doctor per day to answer those types of questions? It's not, we can't ask them to see fewer patients, and it's unfair to expect them to answer those questions at the end of the day rather than spending that time with their family. We have to protect against that. We've got to get out ahead of this so that you're not reacting to this in October and November. But let's look at the far left and the far right-hand side as well. Coder productivity. If you don't have coders in your office, you can replace that with billers. You'll see a significant decrease in their productivity the first year, but they will regain some of that as they get better, as they get more familiar with the code set. But it's not expected that they will get back to current productivity levels. That's not necessarily their fault. It is simply that ICD-10 is more complicated than ICD-9. It will take them longer. So we have to, again, think ahead about how do we make those employees more efficient? Are there any processes we can improve? Are there any tools that we can provide so that I don't have to hire additional staff? And look at the rework productivity on the far right. That's a result of an increase in the denials, rejections coming from the payers. That seems to correspond well to the end-to-end testing results we've seen so far from Medicare. Denial rates seem to be doubling or tripling as a result of ICD-10. That's why most people recommend having a good line of credit in place. You know, you cannot control the payers, but what you can do is make sure that your revenue cycle is in the best shape possible so that you'll be on the low end of that spectrum. You know, groups that have a denial rate of 2 to 3% may see that increase to 4% or maybe as high as 9%. But again, we want to make sure that you're on the low end of that. You know, an ounce of prevention here is better than a pound of cure. So yes, ICD-10 will be hard, and we need to take a good look at the areas where that will be difficult. But it's not going to be impossible. There is a lot of misinformation out there in the marketplace about ICD-10, and some of it is probably intended, right? There are probably people who are trying to use misinformation to scare people about ICD-10. And one of the things that you hear people talk about are the increase in the code set. You know, we have 69,000 new codes compared to only 16,000 in ICD-9. And that's true. Those numbers are both accurate. But the truth is that you never will use all of those codes. Most practices use less than 2% of the code set today. Pay attention to the codes that you use today, see how they convert to ICD-10, and worry about those codes. Let's not worry about the codes that you don't use. Another thing that gets a lot of people distracted is they talk about some of the crazy codes that exist in ICD-10. Right, I'm sure everybody's seen this. This is probably the most infamous ICD-10 code, V91.07XD. It's that flaming water skis encounter. And I get it. It makes for some funny pictures, some funny visual images. It's a good joke. But a lot of people get distracted by this. And what they don't realize is, believe it or not, that code already exists today in ICD-9. It's E837.4. And you don't use it. You'll never use that code in ICD-9. And you'll never use that code in ICD-10 either. Let's not be distracted by the codes that you won't use. You know, a lot of the crazy codes that people like to talk about, they already exist in ICD-9. They're E codes or external cause codes. CMS has already come out and said, if you're not using external cause codes today, there is no new national requirement for you to use E codes. There's no new national requirement for you to use those external cause codes. And this distracts a lot of people. They focus on codes that they're not ever going to use rather than paying attention to some of the more dangerous codes that they use all the time. I'm talking about unspecified codes, because there's certainly a risk to using unspecified codes in ICD-10. A dirty little secret is that a lot of practices use unspecified codes today in ICD-9. They use it as a catch-all. They use it to save space on their encounter form. They use it to make the documentation easier in their EHR. They use it because their documentation isn't specific enough to use anything else aside from an unspecified code. There could be lots of reasons as to why you may use those today. But for the most part, unspecified codes have no negative consequences in ICD-9. They're payable diagnosis codes. But that's not true in ICD-10. There are two risks associated with using unspecified codes in ICD-10. There's a short-term risk and there's a long-term risk. Let me walk through both of those for just real quickly for you. The short-term risk of using unspecified codes in ICD-10 that many practices are probably going to see in the fourth quarter of this year or out into the first quarter of next year is that those claims will get denied. And let me explain why. Think about it from a big picture perspective. Why are the payers advocating for the use of ICD-10? Why do they lobby to keep ICD-10 on track? Why have they spent millions of dollars to rewrite their adjudication process to handle ICD-10? The reason why is they want the more granular diagnosis codes. They want the more detailed information on their patient population. And ultimately, they want to use that data to drive down healthcare expenses. That's what the commercial carriers want. That's what the government wants as well. If the provider community does not give that to them, they are going to deny those claims. Now, that may not happen day one. That may not happen in the first 3 months, right? It may not happen in the first 12 months. Different payers will handle that differently. You know, Medicare has come out this week and said they're not going to deny unspecified codes for the first 12 months, but private carriers will most likely not follow suit there. But there's also a long-term risk associated with using those unspecified codes. The long-term risk is that we're transitioning away from fee-for-service. We're moving towards pay for performance, pay for outcomes, pay for quality measures. And in that world, you need to use the more specific ICD-10 codes if you want to maintain and maximize your reimbursement. In an outcomes-based reimbursement world, it's all about the expected outcome compared to the actual outcome. Right? Now, we're not going to change payment methodologies overnight, but that is certainly coming. And when you look at the short-term risk and the long-term risk together, I think it makes sense. I think it makes sense to make sure that you're starting out the right way. Don't start off with bad habits using those unspecified codes. We want to make sure that you're well prepared to be successful. All right? So there is that short-term risk. There is that long-term risk to using those ICD-10 codes that are unspecified. So I did want to make sure that I talk about that. So let's not pay attention to the codes that you're not going to use. Let's focus on the codes that you will use. And I'm going to start by talking about ICD-10 conversion analysis, because this is where I think you can really jump in and start to make a difference for your practice. We've done this ICD-10 conversion analysis for all of our clients. And when you look at the ICD-9 codes, you'll see most specialties fit somewhere between 200 and 300 codes that they use today that covers the majority of their patient encounters. Now, when you convert that to ICD-10, what you'll see is that everybody has a significant increase, but that orthopedics is the outlier. Orthopedics is by far the most difficult specialty to convert into ICD-10. I'm sorry if I'm the bearer of bad news on that. Now, we go a step further and say you want to, not all codes are converted equally, so we put those into different risk categories. And I'll show you examples of each of these, but I wanted to make sure that I talk about what they mean first. So when we look at this, what we're really talking about is the low-risk codes. Those are ICD-9 codes that have one code in ICD-9, and they have one code in ICD-10. Those are the easy ones. Everybody loves those. Unfortunately, for most orthopedic practice, there's only about 15 to 20% of the codes that they use day in, day out that fit into that risk category. The majority of the codes there fit into one of the moderate risk or high risk categories. Okay, so let's talk about those. Moderate risk means for every one code in ICD-9, there are between 2 and 10 choices in ICD-10. Okay, and then when we get to the high risk codes, that's where most of your fractures, your injury codes will fit. Those codes have 11 or more choices in ICD-10. So let me show you an example of what I'm talking about here. I'm going to show you just some sample ICD-10 conversion analysis. You'll see up at the top the summary data. That's what you see in red. It has the total number of ICD-9 codes, the total number of ICD-10 codes, and then you'll see how many fit in each of those risk categories. But then below, you see the line-by-line detailed information, so that you can see for a code like plantar fasciitis 728.71, there's one code in ICD-9, and it matches up with one code in ICD-10. It's an example of one of those low-risk codes. Let's look at the next one, 71946, knee pain. You can see there are 3 choices in ICD-10, right knee, left knee, and then that third choice, unspecified knee. Now, that's an example of a more dangerous code, in my opinion. Think about what your payers will do. Did you have a face-to-face encounter with the patient? Maybe we had a joint injection or aspiration. Are you going to get paid for that if you use a code like unspecified knee? It's a valid code in the code book. You can go look it up. But is that a code that you want to use? Probably not. Then you can see an example like this closed fracture of the distal radius. You've got a lot more choices in ICD-10. That's where you need to be more specific. I recommend starting and doing this ICD-10 conversion analysis if you've not already. And I recommend that for a couple reasons. Number one, I think it's a great place to start. If you haven't done it, it's a great way to see what the impact is based on the codes that you use most frequently. For people who attend one of our webinars, so that's all of you, we offer this as a free service. If you send us your ICD-9 codes, we will send you back your ICD-10 conversion analysis. If that's something that you want somebody to follow up with you on, or if you want to send that to us, let me know. You can use the questions panel for that. We'll follow up with you on it. Or if you want to email me Excel spreadsheet with your ICD-9 codes in it, we'll send that back to you. Try not to send us any more than 400 ICD-9 codes, just because that ends up taking too long for us to do. All right? That's one reason why I recommend starting here. Number two is it's helpful information to share with your staff and to share with your providers. It usually relieves a little bit of their anxiety. It's not 69,000 codes. And if you look through here, there's nothing about being bitten by a turtle or walking into a lamppost or flaming water skis anywhere to be found. You start to look through the new codes, the new descriptions, you'll see that the clinical concepts, the documentation concepts are familiar, not foreign. And that helps relieve a lot of anxiety sometimes for your providers. Yes, there will be a lot more codes that you need to use, but they're at least somewhat familiar to you. And you can start to get them on board working towards a practical solution rather than just being nervous about it and not making any real progress. And the third thing that I think it helps you do is illustrate that the status quo won't necessarily work. You have to do things differently when you're dealing with 9,000 codes than when you're dealing with 400 codes. So I recommend starting there. Again, for people who have attended one of our webinars, we offer that as a free service. So I think that's a great starting point. If you're a data person, if you like numbers, you're analytical, it's a great way to look at it. If you're more of a visual learner, let me show it to you this way. Now I'm going to pick on the American Academy of Family Practice for a second because they put this on their website. I'm going to use this as an example of how to compare ICD-10 productivity and ICD-10 compliance. This is a super bill that they recommend their members use. CPT codes on the front, diagnosis codes on the back. Pretty simple. What caught my attention was they had an ICD-10 version, and it looked like this. The front side stayed the same, no changes there, but the back side looked like this. It was 8 pages long, and that's family practice. Orthopedics would be closer to 40 pages long. But 8 pages versus 40 pages, it really doesn't matter. Neither of those are productive ICD-10 solutions. They may be compliant, meaning they've got the right codes on there, they've got the right descriptions on there, they've got all the necessary choices. They're compliant, but they're not productive, right? Now, some of you may not be using something like this, but I want to use this as an example, right? 8-page super bill won't work, and a jumbo super bill won't work either, right? There's not enough physical space on an 8.5 by 11-inch piece of paper to list the codes that you need for an orthopedic practice. And if you've got a bit of a different process, maybe you don't list out your diagnosis code, you have doctors that write in a description, and somebody looks up the code later. Maybe you have coders or billers that code from the documentation. Maybe you're doing that in your EHR. But you've got to keep in mind, it's not just the codes that change, but the descriptions change as well. They're more specific. They're more granular. The documentation concepts are changing. They're more detailed. And if you've got doctors writing in a description and they write in OA knee, or they're dictating OA knee, or that's what they put in their note, that's not specific enough to get a specified ICD-10 code. You're going to be right back to that Canadian problem that we looked at of the back and forth between the coder and the doctor, the biller and the doctor, that was taking 45 to 90 minutes per day. That's what we want to avoid. So when you're looking at a problem like this, anything in your ICD-10 plan, one of the things to do is think about how does it work today and what makes it work so well today. We did a national survey last fall to look and see how many practices are using paper charge tickets like this. And we found 54% use a paper charge ticket. Even those groups that have an EHR installed have a high percentage of clients and practices that use a paper charge ticket. What makes that work so well in a practice today? It's the doctor's muscle memory. They know where the codes are on the page. They can probably fill it out with their eyes closed. That's what makes it work so well for the doctor. And it gives the billing team all the data that they need to be successful. So what have we seen clients do? Let me walk through 3 options of what we've seen clients do, and I'll talk through each of them. The first I see more in the hospital setting than I do in the practice setting. And it's because it's an economic problem. There's not enough. Coders are expensive, and you have a high volume in the office. It's hard to make those economics work. The challenge of that strategy for ICD-10 is that coders are getting more expensive, and at the same time they're going to be less productive in ICD-10. So if financially it didn't make sense for you in ICD-9, it's going to be very difficult to make those lines cross for ICD-10. I do want to mention that, but I see a lot more practices trying option 2 or option 3. So let me spend a bit more time there. Option 2, this may be easy for me to say on the webinar, difficult for you to implement in your practice, but just get all your doctors to do it correctly in the EHR, to go through all of the steps. Now, typically when practices struggle with this, it's not because the doctors are technology averse or the doctors are non-compliant. It's they're worried about their productivity. They say it takes them too many steps, too many clicks to do that. They're worried about their time. And because that's what they get paid for. They have to be worried about that. The challenge is for the project manager who's working on this is if it's difficult for the doctors in ICD-9, it will be much, much harder for them in ICD-10. For an orthopedic practice, that's the most difficult specialty to make that conversion. And this is why you've got to think critically about it and ask the next question. Don't just ask your vendor if you're going to go down this road, will you be compliant for ICD-10? Because the answer will 100% of the time be yes, of course. But when you ask the how, when you say show me, don't show me primary care examples, show me orthopedic examples. Show me the fractures, the ones that are going to be really hard. Because many vendors have solved this problem through code search. And again, that sounds like a good idea. It sounds like a good solution. After all, everybody wants to be like Google, right? That's the word we use for search. And search is easy when you're doing things on Google, right? When you're looking for an apple pie recipe, right? Or an Italian restaurant. Or you're looking for who sings that song, Google knows the answer. And 99% of the time, the answer is one of the first 2 search results on Google. That's why everybody fights for the top spot on Google. But it doesn't work on code search. If you search for a fracture radius and get hundreds of choices, you have to read through every single one of those to choose the one that's most accurate for that patient. It's like an SAT test. And oftentimes, if your doctors aren't going to read through all of them, if they're going to read through the first couple and choose one of the first 3, oftentimes the unspecified codes are at the top because of the way the code set is structured. If you're sorting by diagnosis code, often the unspecified codes will be at the top of the search results. That's why you have to understand how it's going to work and see the examples to make sure that it's going to produce the outcome that you're after. Now, I'm certainly biased, but I think the third option is the best way to handle this for an orthopedic practice, and it's an electronic superbill designed to look like the paper superbill that protects the doctor's muscle memory. It minimizes the amount of training time required and makes it very fast for them to use, but at the same time making sure that the billing staff has the right codes, has the right data that they need to get the claim paid correctly and completely the first time without spending a lot of time on the back and forth process with the provider. Right? So that's what Excelicapture does. So let me, sometimes a picture's worth 1,000 words. So let me show you how that works. I'm a visual learner, so this always helps me. I'll show you some examples of those low risk, moderate risk, high risk codes. This is Excelicapture. Again, the electronic superbill is custom designed for each practice. We want to make that look as similar to your paper superbill as possible. I'm going to do one encounter in ICD-9, and then we'll turn around and do that exact same encounter again in ICD-10. So let's do ICD-9 first. If I've got a level 3 office visit and an x-ray and a short arm cast, I'll flip over to the back side. I've got my diagnosis codes. Again, instead of circle, 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 I'm just going to do click, click, click. Plantar fasciitis, knee pain, and then fracture distal radius, right? Pretty simple for me in ICD-9. Everybody gets that. Everybody understands how that works. Now, I'm going to leave these side by side so you can watch when I do it in ICD-10. And here's what I want you to think about. Pretend that I'm one of your doctors. I haven't come to any of your ICD-10 training classes. And now I'm going to walk in. It's Thursday morning, October the 1st, and I'm going to try to do an encounter in ICD-10, my first one. The front side stays the same, right? No changes to CPT codes. We already talked about that. So far, so good. Let's look at the back side. Is it 40 pages long? No. This is the magic of what you can do with an electronic superbill. It looks exactly like it did the day before. Nothing has changed. All right, so far so good. Let's click on plantar fasciitis. Watch this. This is the first time you'll notice that anything is different. It converted that into an ICD-10 code for me automatically. It put in the new ICD-10 code, the new ICD-10 description. It highlighted it in green, which is just a visual cue to me as the user to know that something is different. It's an ICD-10 code. I'm done. Great. I love that. Okay. I wish everything were that simple, but it's not. So let's do a moderate risk example like knee pain. When I click on that, you'll see it cannot convert that for me automatically. So it gives me a pop-up. And it shows me my choices for left knee, right knee. Now you'll see it does have that choice for unspecified knee. This is where coding is part art, part science. That's a valid ICD-10 code, but you may not want to show that to your providers. Many of our clients are deciding not to show that option. There's a configuration setting that says, don't show me any of the unspecified laterality codes, because you've got 2 knees and 2 hands, but I've never seen anybody with a 3rd foot, right? I don't want to use that code. So if it's in the right knee, one extra click closes the pop-up window for me automatically, puts in the new code, puts in the new description, right? So far, so good. All right, well, let's look at a fracture. Let's look at one that's really bad, right? If I search for a closed fracture of a distal radius, I'd get over 250 search results. Let's see how we organize that here. What you'll see is we've defaulted that, we've organized it into 3 dimensions, and we've organized it to default to the initial episode of care. Now, I could change that to a subsequent encounter for routine healing, but I'm not going to. I'm going to come back to that in just a minute. And then we've taken the type of fracture and put that on the vertical axis, and the laterality and put that on the horizontal axis. And what that lets me do is very quickly go, oh, it's a Barton's fracture, it's the right distal radius, one extra click, closes the pop-up window for me automatically, and I'm done. Now let me go one step further, because a lot of our clients still have some doctors who are dictating or documenting manually. If I go to this summary tab on the rank and link, it shows me a summary of everything that's been selected. A lot of clients like to use the super bill as a reminder for who they saw and what they did when they do their documentation later. They can come back and access the electronic super bill to see that, or some people have staff print those out for them. And what that allows them to do is show them where they need to be more specific. Instead of just saying knee pain, I need to specify the laterality. Instead of just saying fracture radius, I need to say Barton's fracture right radius, initial encounter for closed fracture. Now I have all of the elements required for ICD-10 in my note. Rather than spending a lot of time to learn the new documentation concepts over the summer, that allows me to learn as I go and have that reminder of where I need to be more specific. All right, now I want to show you one more thing that's unique to orthopedics, because your patients are typically episodic. They're going to come back again and again and again, oftentimes for the same problem. So our clients love to keep a section at the top of the super bill that says, hey, it was the same thing that I saw them for last time. That works great in ICD-9. Let me show you how it works in ICD-10. Exact same thing. It's got the ICD-10 code in it for plantar fasciitis, no problem. Knee pain, no problem. I don't even have to see a pop-up because it's still the same knee. Now on this one, Barton's fracture right radius initial encounter for closed fracture. I probably don't want to use that initial encounter code again. So when I try to click on it, it gives me the pop-up and shows me the other choices. It's still a Barton's fracture. It's still the right radius. It's still a closed fracture. I just need to be more specific about the healing type. Is it routine healing, delayed healing, non-union, malunion, sequela? Hopefully, for your patient's sake, it's routine healing. One extra click, puts in the new code, puts in the new description, and I'm done. Remember, the goal here is to make ICD-10 a non-event for your providers. That's what we want to do. We want to make it easy for them so that they can remain focused on taking care of your patients. Now, let me spend the last few minutes talking about the revenue cycle process, because I've spent a lot of time on the doctors. Let me talk about the revenue cycle, and then I'll try to get to as many questions as I can, because it is a big change for the revenue cycle team. Right? And it's not just a one-day change for them. They're going to be dealing with the changes to ICD-10 in the months and years following October 1st, 2015. When you think about it from a high level, we get paid, we're still in the fee-for-service world, we get paid for CPT codes, and you have to have a diagnosis code that makes it medically necessary. That's true in ICD-9, that's true in ICD-10. If only it were that simple, right? You have to jump through all the hoops and hurdles from the payers in order to get those claims paid correctly, and not all payers want that done the same way. You've dealt with this for the past 30 years in ICD-9. You may have people, billers in your office, who know the ins and outs of that game very, very well. They keep up with it. They learn as they go. The problem is that head knowledge, that cat and mouse game, is going to change overnight. All of that head knowledge goes out the door. The cat and mouse game is going to continue, but the rules of that game is what's going to change. And again, not all payers are going to handle that the same way. Remember, the payers have never done ICD-10 before either. They're going to be learning as they go. And that means they're going to be making changes. It's not just a one-day change. You're going to have to keep up with the changes that they make. And again, if they haven't done this before, the volume of changes is going to be very, very high. High change environment, much more so than anything we've ever seen in our careers. So if that's what the new world is going to look like, you've got to ask yourself, okay, what does that mean? What types of tools, what types of processes do we need in place to manage that? Who on my staff is going to manage that and keep up with that? And maybe the scarier question is, what happens if we don't do a good job of that? What does my cash flow look like as a result? For your revenue cycle process, this is a marathon, not a sprint. And if you're going to run a marathon starting in October, the best thing that you can do is get in shape now. Right? You can't get off the couch and run a marathon starting in October. You've got to prepare for that in advance. And so what we recommend for all of our clients, anybody can do this. We certainly provide some software to try to make this easier, but anybody can do this, is put in a process. We call it closed-loop denial prevention. So here's what we tell our clients. You can't rid the world of denied claims. You're always going to see new denials. Payers are going to continue to change the rules of the game. But when you see a new denial, when you see a new policy, go back to the beginning. Figure out what went wrong and what you could have done to prevent it, and then build in a new rule. That way, the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, you make sure that that rule fires the exact same way every single time for every single employee. Whether it's my most senior certified coder or my newest billing clerk, they get the right actionable information at the right point in time in the revenue cycle so that the claim goes out the door correctly. You cannot control the payers, but you can control your process. So you want to get your denial rate as low as possible today. And you want to make sure you've got a good process to responding to those types of changes when you see them. Okay, now last slide, because this is, and then I'll try to answer your questions. But what I want you to think about is, what do you want your office to look like in October of this year? What do you want your practice to look like in November of this year? And what is the goal? Is the goal ICD-10 compliance, or is the goal ICD-10 productivity? Is the goal simply to be able to submit claims that have ICD-10 codes on them? Or is the goal to optimize your workflow, to make sure you protect your doctor's time, protect your biller's time in ICD-10? Because I don't want my doctors staying late to answer coding questions. I want them to remain focused on taking care of our patients, because that's what they went to medical school for. That's why they got into medicine in the first place. And that's what our patients expect as well. Your patients aren't thinking about ICD-10. They're going to expect the same high-quality service that they get today. And what about your billing team? Are they going to be working nights and weekends to get claims out the door and to manage the back-and-forth process, asking your doctors for follow-up information, chasing them down to get that information? Or are we going to make sure that they get the right code the first time? They have the information that they need to do their job. Are they going to have the tools that they need to respond to the changes that come from payers? Or are we going to have to hire additional employees to follow up on denied claims? Or am I going to have to outsource part of my AR follow-up? The challenge with adding additional employees is that ICD-10 is an unfunded mandate. There's no additional revenue for the practice. And if you've got to hire additional staff and there's no additional revenue, the only outcome possible is that the practice will be less profitable than they were before. And it doesn't have to be this way. You can get out ahead of this rather than realizing this at the last minute or realizing this when you're unable to pay the physician quarterly bonuses at the end of the year. It doesn't have to be this way if you can get out ahead of it and take the necessary steps to mitigate the risks for your practice. There may be even places where you can improve processes and make the practice more profitable. But you've got to get out ahead of it. Now, I know I've went through a lot of information today. I covered it quickly, but I hope that this has been helpful for you. I hope that this encourages you in your ability to successfully transition your practice to ICD-10. I'll try to answer as many questions as I can, but thank you again for your time this afternoon. I hope this has been helpful.